Hello, we are the Association for Child and Adolescent Mental Health, or ACAMH for short.
I'm Professor Courtney Norbury. I work at University College London in the Department of Psychology and Language Sciences, and I'm a joint editor of the Journal of Child Psychology and Psychiatry. I've edited a special issue of the journal that focuses on child language disorders. The reason for focusing on this topic is that language is central to all that we do. It's important for initiating and maintaining our social relationships, for learning and for children's academic success. It underpins our ability to learn to read, and it's associated with good mental health outcomes. Now, for most of us, we learn language without even thinking about how we do it, and it seems pretty natural and easy. But for some children, acquiring their own language is a very difficult and protracted process. And these children have language disorders. Sometimes we know that these language disorders might be associated with another clinical condition, for example, autism. But sometimes children present with language disorders that aren't explained by any other condition that they might have. And these are children that we will call children with developmental language disorders. JCPP has a rich history of publishing work in this field, going way back to the 1970s with seminal work by Rutter, Bartak and Cox, who reported the first explicit comparison of the language profiles of children with autism and children with language disorders of unknown origin. In addition, if you study language disorders for any length of time like I have, you'll be very familiar with Dorothy Bishop's 1992 paper on the underlying nature of specific language impairment, in part because it runs to 62 pages of information about what we knew about language disorders at that time. I had a look at that paper again in preparation for this special issue because Dorothy Bishop once again leads the pack in this special issue with a paper on terminology. And I was particularly interested in looking at her 1992 paper because the first paragraph explains the history of terms that we use to describe children with language disorders. And I'm pleased to say that after all of this time, 25 years, we finally have consensus on how we should refer to children who have language difficulties. And the term that we have decided on through an international consensus is developmental language disorder. Dorothy describes the reasons for this in the catalyzed paper and how we came to this consensus using a multidisciplinary team from across the English-speaking countries. This is a really important step forward because we know that developmental language disorders do not have the same public awareness that difficulties like dyslexia and autism spectrum disorders do. And we hope that using more consistent terminology will raise awareness of the needs of these children in the general public and increase the pace of scientific discovery with regard to underlying causes and in the future intervention as well. In addition to the very influential catalyzed paper, there are 9 other papers that explore the longitudinal course of language disorder, the impact that it has on children's lives, potential for intervention to change and improve children's language outcomes, and an exploration of language performance in children with other clinical conditions. So I'll just tell you a little bit about each of those sections. So there are 2 papers that look at longitudinal development in the primary school years. One was conducted by Christina McKean and her colleagues in Australia using the ELVS cohort, and one was conducted by myself and the Scales team using a cohort of children recruited from state-maintained primary schools in Surrey in the UK. And these studies use quite different populations. The Australian study recruited children at 9 months of age and followed them through to 11, and they excluded children who had other known clinical conditions, but they included children who were learning English as an additional language. In our work, we recruited children at school entry, and we took all children regardless of their clinical status or their intellectual abilities. However, we excluded children who were learning English as an additional language because we investigated their skills in a different study. The 2 studies also use quite different statistical approaches. In our study, we identified the clinical categories a priori. So we had children who had language disorders of unknown origin and children who had language disorders that were associated with a known clinical condition. and we tracked their progress relative to typical peers over the first 3 years of primary school. In the McKean study, they didn't use any a priori classifications, but instead looked for different language trajectories that just arose from the data, a latent trajectory analysis. Despite all these differences, the two studies converge on very, very similar findings, and that is that although you can see improvement in children's raw language scores over developmental time, their performance relative to typically developing children is very stable. The really important message from both of these studies is that we can be fairly certain if a child presents with language disorder at the age of 4 that these difficulties will be persistent over time. An important question then is what we can do to support these children. So there are 3 studies that look at intervention in this special issue. So the first study by McGillian and colleagues looks at the impact of increasing parent contingent talk on the early vocabulary skills of children from socially, economically deprived backgrounds. The reason for focusing on this particular group is that we know there are early social gradients in language, such that children who come from more deprived backgrounds tend to have lower vocabulary skills overall compared to more advantaged peers, and that differences at school entry set the course for language learning. In this study, they randomized parents to receive either a very brief intervention which talked about the importance of providing contingent talk to toddlers, or a control condition which looked at the importance of brushing your teeth. During the course of intervention, parents were asked to practice contingent talk with their toddlers for 15 minutes a day, every day for a month. At the end of this month, 12-month-olds who had received this particular intervention showed increase in vocabulary that was associated with apparent increase in contingent talk relative to peers in the comparison treatment. However, when these children were followed up again at 24 months, this advantage had disappeared. This suggests that although it is possible to change parent behaviour and that this may well have an effect on children's language, you need to provide a consistent type of input in order to maintain these effects. The other 2 intervention studies focus on preschool children and look at intensive targeted interventions in the classroom. One study was conducted in Norway by Hagen and the Lervags, and one study was conducted here in the UK by Silke Frick, Charles Hume and Maggie Snowling and their colleagues. Both of these studies provide quite intensive input of at least 3 times a week over the course of a year. These studies are encouraging in showing that this level of intensive input does yield significant differences in language performance in those children who have received the treatment relative to peers who are in a treatment as usual condition. However, there's a couple of things to bear in mind. First of all, the effect sizes tend to be small to medium. And in addition, at least in the Frick study, these improvements in language did not show immediate transfer to reading. It's possible that you will see these if you follow children up over a longer period of time, but this is an important avenue for future research. The other thing is that they didn't recruit children with clinical diagnoses, so we don't know if these treatment effects would be seen in children with the most severe language disorders. However, both groups looked to see whether there was a differential impact of the treatment depending on the initial language severity, and there wasn't. That means that children who had the most severe language difficulties made the same amount of progress as those with milder difficulties, and this is great. However, like the longitudinal studies, what these intervention studies show is that it's very difficult to narrow the gap. So everybody's improving at the same rate, but in order to narrow the gap, we need children who are at the bottom of the distribution to learn at a faster rate. And the studies that are reported in this special issue seem to indicate that that's a very tall order indeed. 2 studies report very rare but extremely negative and worrying consequences of developmental language disorders. The first study comes from the Canadian group who reported one of the first epidemiological studies of language disorder that started in the 1980s. This paper by Brownlee and colleagues looks at adult reporting of child sexual abuse in women who have a history of mild to moderate language impairment. What this study shows is that girls who experience language disorders were almost 3 times as likely to report child sexual abuse than peers who did not have language difficulties. Although this remains very rare, it's really critical that we understand how vulnerable some children can be. It may be that children with language disorders are more vulnerable to this type of abuse because perpetrators know that they may be less likely to disclose what's happened to them, or their ability to provide a coherent account of what has happened to them will be diminished. Although this type of sexual abuse remains quite rare, it's important to consider that in the normal course of development, young people with language disorders remain vulnerable, particularly as they develop and encounter their first sexual relationships. Adolescents with language disorders may be less able to negotiate or express their needs or let people know when things aren't right for them. They may also have less secure friendship networks and may not know how to talk about their complex feelings with other people. We have very little research on how to support adolescents with language disorders, and this is, I hope, something that we'll see more of in the future when we're taking research papers at JCPP. The other study by Hughes and colleagues looks at the language skills of young people who have been incarcerated in young offender institutes. In this study, they assessed the language skills of young people in young offender institutions and reported that about 40% of these young people had lower than expected levels of language for their age, and 20% met clinical criteria for developmental language disorder. The most shocking thing was that very few of these children had ever been seen in specialist clinical services prior to their incarceration. And this suggests there are many missed opportunities for services to pick up children who are having a really difficult time. Once again, language disorders make children very vulnerable to understanding and following rules, and if they are arrested, to understand the processes that are involved with interviewing, with their rights, and with providing an accurate and detailed account of the circumstances that led to their arrest. There's a lot of work being done now in supporting children in young offenders institutes, and a clear need for there to be more studies about how we can catch these children earlier and support them throughout their development. Both studies really highlight that children with language disorders, as are children with other developmental disorders, at greatly increased risk for maltreatment and adverse developmental consequences. And understanding these relationships is clearly important for future research. The last 2 papers in the special issue consider language skills of children with different developmental conditions. The first, by Hopkins, Ewell and Brannigan, is a much more experimental paper than we often accept at JCPP, but I wanted to include it because it focuses on a potential area of strength for children with autism spectrum disorder. So in this paper, they were looking at children with autism and their ability to engage in something called lexical alignment. And this is the phenomenon whereby, as skilled communicators, we tend to unconsciously agree on a set of terms to use to refer to different objects, even if they might not be the terms that we would preferentially use. So for example, if my communication partner keeps referring to a pony, then I'm more likely to use the word pony than horse, even if I myself might think of it as a horse. Now, what they set out in this paper is that this skill relies both on your social understanding of What they set out in this paper is that the ability to do this may well rely on your social understanding and your understanding in particular of your communication partner, but it also relies on executive skills, particularly inhibition. So you need to inhibit the word that you would normally use in order to engage in this lexical alignment. And using a really clever experimental paradigm, they were able to demonstrate that children with autism were as likely to use lexical alignment terms as typical peers, and that their ability to do this didn't relate to their overall executive skills. So this seems to be an area of strength for many children with autism, and that's a good thing to know. Of course, it might have to do with the highly structured situation, but this too is interesting in demonstrating to us the sorts of structures that will help children with autism to succeed on communication tasks. The final paper is by Mandy Skuse and colleagues, who reports on social communication disorder. This is really the first attempt to try and implement the diagnostic criteria set out by DSM-5 for this new and highly controversial clinical condition. They looked at the clinical case files of more than 1,000 children who'd come to their specialist clinic for young people with social communication disorders. They were able to distinguish children who had social communication difficulties but did not meet full criteria for autism versus children who met full criteria for autism, and another comparison group who had developmental difficulties but did not meet criteria for either. They did find a proportion of children who met diagnostic criteria for social communication disorder, and they reported that the distinct diagnostic criteria were moderately correlated. However, they reported that their symptoms were not qualitatively different from what is seen in autism, but rather that they just weren't severe enough to meet full criteria. So, as has been reported in the past, this clinical condition seems to be an intermediate grouping of children who just don't quite meet criteria for autism. Whether they have a different underlying etiology is something we just don't know yet, and hopefully future studies will tackle that important issue. In the meantime, it seems there might be some utility to this diagnostic criteria in that it identifies children who may be struggling to communicate and the impacts that this will have on their lives. So these children may need support even though they don't meet full criteria for autism. In sum, it's been a fantastic special issue and a great opportunity for me to really see where the state of the art of the field is now. In doing so, we can see that there are some big gaps in our knowledge that hopefully will be filled in the next 25 years of JCPP. To me, there are a couple of key issues that future research really needs to address. The first issue, I think, is that we need more high-quality RCTs that examine intervention in children with clinically identified and severe language disorders. DLD is a more inclusive diagnostic term. We no longer require that children have discrepancies between verbal and nonverbal IQ in order to obtain a diagnosis. And yet we have almost no intervention studies that include children with lower levels of nonverbal intelligence, and we have no idea whether this makes a difference to their response to treatment. We also understand more now about comorbidities. So many children with language disorders will have social difficulties, attention difficulties, and how these impact response to treatment is also something we know very little about. And this is critical for planning the sorts of interventions that we can offer and who is most likely to benefit from them. The other thing that we don't see very much of are studies that look at the cascading effects of interventions on other aspects of development. Most of the time, if people look at cascading effects, it will be on literacy, and the research here has yielded some mixed effects. As I mentioned, the Frick study looked to see whether improvements in language yielded improvements in reading. And at least at this age, there was no evidence that that was the case. It might be that this has a greater impact on literacy if we intervene later or perhaps even earlier. But we also know that language disorders increase risk for social, emotional, and behavioral deficits. And it would be wonderful to know whether improving language early on attenuates these emotional difficulties later on. And we would hope that by improving language, we improve children's mental health throughout the developmental period. Timing is also an important issue. So when is the best time to intervene? In this special issue, we've seen studies that have reported on improving parent-child interaction in toddlerhood, and studies that look at developing children's language skills in the preschool years. But we know very little about whether concerted efforts to improve language during adolescence or even in adulthood would have any meaningful impact on children's daily lives, and this is clearly an avenue for future research. Finally, the studies reported here show that language disorders are persistent, and that means that adults are likely to require ongoing support. Indeed, those early studies by Michael Rutter have had longitudinal follow-ups of individuals into adulthood that again have been reported in the pages of JCPP. And it is clear that the impacts remain wide-ranging. So studies that look at the impact of adult support for individuals with a history of language disorder will be really important in understanding how we can get the best outcomes for these young people and their families. So I look forward to new research that takes this field in new and exciting directions, and I do think that the research reported in this special issue will lay a great foundation for that future work.
To be part of the advancement of child and adolescent mental health, visit www.acamh.org.